Let me start with picking up where Dr. Brian Sims left off. How many of you have heard of Dr. Bruce Perry? Okay, we have a fair number of folks who know Bruce Perry, who is really one of the premier trauma specialists out there, psychiatrist. And I just want to touch a little bit on some of the theories that Bruce Perry has taught us in terms of brain development. Then I'll go a little bit in terms what happens to our body. Brian talked a lot about what happens to our brain. We'll talk a little bit about what happens to our body as a result of the trauma, and then also connect that in terms of neglect. Bruce Perry tells us basically that our brain develops from the bottom up. This is pretty straightforward, bottom up, which is basically your basic functions, your basic fight, flight, or freeze comes from the lowest part of your brain, and as a result of interactions with the environment, your brain develops. With me? That makes sense. Okay, so for example, how many of you have children? Okay. You bring that infant home, that infant starts to cry, you pick up that infant, and you start rocking. Okay? And you cannot remember how many hundreds of times you did that. Sometimes against your will. Bruce Perry calls that patterned, rhythmic, repetitive movement. That rocking is a patterned, rhythmic, repetitive movement. And that by doing that patterned, rhythmic, repetitive movement, what you actually were doing is developing that part of the brain that's in charge of self-regulation. Because by doing that, the part of the brain develops that tells that child, if you need comforting, someone will come and comfort you. Still with me? So that patterned rhythmic, and then that child begins to grow up, and that self-regulation becomes more internal. So you may not necessarily be there anymore to do the rocking, but that child is a pacifier. And that pacifier is actually patterned, rhythmic, repetitive when they suck on that. So these parts of the brain develop. We also have science that tells us that there's fluid between our ears that when it moves, it soothes us. How many of you have seen people crying and they're rocking? Right? Pretty common. So this part, this afternoon, what I'll delve into a lot are practical applications. If we know patterned, rhythmic, repetitive movement helps soothe people, if we know there's fluid between the ears that when it moves helps soothe people, where are the rocking chairs in your programs? She's got one. Think about this. This is where you begin to understand the science you're learning today and begin to apply the science to the work you're doing. How many of you have seen airports now have more rocking chairs showing up? Because a lot of people are anxious about flying. So think about that. Think about rocking chairs. Sports. How many sports are actually rhythmic, repetitive movements? Basketball and all kinds of sports. I was at tennis. I was talking to a friend of mine who plays tennis, and I was talking about rhythmic, repetitive movement, and he said, Raul, it's even before we serve. Have you seen people before they serve? They're rocking. They're centering. So, where are the sports programs in your community? If we begin to apply the science, we need to begin to understand that that needs to show up in our systems. So that's what Perry talks about in terms of the brain develops from the bottom up. And I'll show you a slide a little later in terms of explaining that. The other piece around the brain develops from the bottom up, and at the bottom of the brain is where your fight, flight, or freeze is. When there's a trigger or traumatic cue, or a threat cue, blood from the top, which is your cortex, comes back down to the bottom of the brain to prepare your body to fight, to run, or to freeze. Still with me? Makes sense, right? If there's a traumatic cue, and if your fight, flight, or freeze is here in the brainstem, The blood goes there. That's why your blood pressure goes up. Your temperature may go up. If you're ready to freeze, your blood pressure will drop. Your temperature will drop. Your body will prepare for fight, flight, or freeze. Still with me? The blood goes from the top to the bottom. So when we're faced with someone having a hard time, what's our most common strategy? Tell me what's wrong. Blood ain't there. Think about this. We usually follow that with, how can I help you if you don't tell me what's wrong? So now the science is telling us when someone's having a hard time and they may be getting triggered, stay out of the verbal world. That's why that comfort versus control makes sense. Go for the comfort world because it's not there. I don't think Brian really got into the PET scan. I don't think he showed the PET scan this morning. One of his slides is a PET scan that actually shows when someone is reliving trauma. They did PET scans of what parts of the brain is firing. They showed the amygdala, the fight, flight, or freeze is firing. Makes sense. When someone is not re-experiencing trauma, they show the Broca's area is firing, but not when someone is re-experiencing trauma. Anyone know what the Broca's area is for? Speech. Again, it tells us when someone is reliving the trauma, the Broca's area, the speech area, is not firing. So stay away from the verbal world. Okay, so those are some of the implications. Let's talk a little bit about what happens to the body. So Bruce Perry and his team get called for all types of disasters. They were there for 9/11, Virginia shootings, and all of that. They were there for Waco. You guys remember Waco? You remember for Waco, there was that first siege, that quiet time, and then that second siege? Perry and his team were at Waco during that quiet time, studying the children, the traumatized children. They studied the children while the children were at rest, watching TV, doing nothing, whatever. And what they did is they took blood samples. And what they found was the traumatized children at rest had 40% higher serum cortisol, stress hormone, going through their system compared to a normal child. 40%, doing nothing. The analogy I use for this is it's after lunch, I'm beginning to bore you. If you are engines sitting here, you're probably idling at 20 miles per hour. The people we serve with that much stress hormones, serum cortisol going through their system, are probably idling at 60 miles per hour. So I want you to begin to think about when we hear, oh, so-and-so just went from 0 to 100, just like that, that person may have gone from 60 to 100. So the point is in your service system, think of your service system. If the majority of the people in your service system are idling at 60 miles per hour, and half of your staff are idling at 60 miles per hour, what your service system look like? That's why when Brian was talking about social environmental interventions, the interventions need to be on the stimulus side, remove as much trigger as you can within your systems, because the majority of folks are idling at 60 miles per hour, and it doesn't take much to get them to 100. Make sense? And this is where you begin to really look at this. So for example, you're talking to law enforcement. Think of how high someone who is behind a door when the police are banging on the door. Think of the stress hormones in that person's system. And by helping law enforcement understand this and understand that that person is idling probably at 90 miles per hour, our task is to help that person drop a little instead of getting that person to 100. Another research here, I think, this is by Bremner. What Bremner did is they took individuals with history of trauma and told them to write their trauma story. After writing the trauma story, they said to them, we're going to read back the trauma story, your trauma story to you at such and such time. They took blood samples. An hour before the reading and through the reading, the individuals had 60% higher serum cortisol. Imagine how high that is in terms of stress hormones. So what are the implications for this? Whether you're running a drug court, you're running a probation office, someone is going to go see the judge. You think they'll be revving at a higher rate? In anticipation, this is an hour before in anticipation of reading of a trauma story. 60% stress hormone. Take a child who keeps failing in math and is going to school with a math test. In anticipation, that person's stress hormone. So maybe our programs should have basketball before school. We need to help people release those stress hormones. There's a video going around on YouTube. I think it came out of 60 Minutes. And I don't know how many of you have seen it. It's called Young Autistic Girl Suddenly Communicates. Anyone seen the video? Awesome. If it's still there, I think they pulled it because 60 Minutes, I don't think like it's on YouTube. But basically, the story is this young girl who's got severe autism. The parents did everything in their power to keep her at home and homeschooled her and all of that. At age 13, she discovered a computer and she started typing. So she can communicate now by computer. One day, she typed to her father, I want you to imagine a can of soda that is shaken. She said, I bang my head because that's what it feels like inside. I need to let some fizz out. Is there a more poignant description of what that might be like inside? So what I'm saying to you is, the people we serve and some of our staff who are revving at 60 miles per hour with that much stress hormone have to find ways to let fizz out. And you need to begin to look at your programs and understand how do you do this. So what are some examples for this? I don't know, for those of you who are in 24-hour programs, have you noticed that evening time tends to be the more difficult time in programs, especially around, I'm seeing nodding. I actually call it sundowning. We're seeing this in a lot of programs. As the sun starts to set, you can feel the anxiety going up in the program. Think about it. When does abuse occur? So as dark starts to settle, you begin to see the increase in anxiety. Programmatic implications. If 6, 7, or 8 p.m. are the hot times in a program, why do the senior clinicians leave at 5? This is where we need to begin to understand that there's science and we need to have our practice follow science. So, things are revving up. So what are some of the things that you may want to think about? If you know that the evening shift is beginning to be some more anxiety-provoking, what we do is we put in programs that bind anxiety. For example, setting the table for dinner. It begins to prepare people that sundown is coming. It's beginning to help bind that anxiety. Phone times. In a lot of 24-hour programs, when is the most common time for phone time? Evenings. So not only are people anxious about sundown, anxious about nighttime, now they're probably talking on the phone to their abuser. Think of the program. So if you know evenings are high risk times and That's also when phone times are. What programs do you have so people can bind their anxiety before they go to bed? Some examples of that. We hold community meetings in some of the programs in the evening. The way this is structured is shift report, change of shift. The outgoing staff cannot leave unless they give and report an accomplishment of the people they worked with. Evening community meeting before they go to bed is only identifying one thing a person was successful in that day. And if they cannot identify that, the staff are armed with information from the morning shift of what they accomplished that day. So we send people to bed on success. Think about that. You know evenings and bedtimes are difficult. You need to make your programming follow on this kind of understanding. Is this making sense? So there's lots of different ways to help people manage those anxieties. So we'll talk a little bit about self-regulation, and Brian talked about this. So how many of you use wellness recovery action plans? RAP? Do you do RAP in your programs? Okay, we've got a few. How about crisis safety plans? Oh, okay, great. So crisis safety plans are pretty straightforward. It's basically a plan that identifies triggers, identifies early warning signs, and identifies what helps people to calm down. I'd encourage each of you to have your own crisis safety plan. Your partners would appreciate it. Not many of us actually understand what our early warning signs are. We just blow up. So, triggers, that's pretty straightforward to help understand what the triggers are. Early warning signs. Your body tells you when you're anxious. Bessel van der Kolk out of Harvard has significant research on this that talks about trauma lives in the body. Your body tells you when you're anxious. What are some of the signs for you guys when you're anxious? I can't hear. Heart racing. Okay. What? Shortness of breath. What? Poor focus. Okay, so we all know what happens to us, right? Usually my deodorant fails me. We all know. But I want you to imagine this. Imagine, say, an adolescent that with your work, and this goes back to what Brian was talking about, going back after incidents, with your work was able to identify that when my forehead sweats, I'm getting anxious, which means he may be getting triggered but doesn't know what the triggers are. That's later in the treatment. Right now, you help him identify when his forehead sweats, he's getting anxious. That youth is sitting in a classroom. His forehead starts to sweat. He now can say, "May I go to the bathroom, please?" Doesn't know what's triggering him, but he knows now to take himself out of the classroom because something is triggering him. In the past, he would sit there until he blows up. Isn't that a lifeline? That's what we're talking about. Begin to help people to get strategies. So by having that early warning sign, that person, you prevent that person from going to the response. Because with the early warning signs, that person can do something. Make sense? So that's basically crisis prevention planning. Help people with triggers, early warning signs, and strategies. There are many different types of triggers out there. Bedtime. Okay, I'll give you another. Here's another strategy that I have seen work. A lot of individuals with trauma say to us, which is really part of the power differential that occurs in traumatic and abusive relationships, that there tends to be a tape recording in their head that says you're nothing, you're worthless, and you probably deserve what you got. That's part of the message of the abuser, isn't it? So that tends to stick with people who have history of trauma. Now, when someone's getting triggered, in a lot of our programs, our most common strategy is to send them to their room or send them someplace quiet where they can hear the recording louder. Think of strategies. If we know someone's getting triggered, and that could be part of the trigger is that recording is getting louder, the strategy is diversion, not go somewhere where you can hear it louder. Make sense? So that's why you have to understand what triggers are. So lots of different triggers. Contact with family, particular time of year, all of this. I was called to a program. And the other thing with crisis safety planning is do it and also use it. So for example, part of crisis safety planning is identifying, we've done early warning signs, strategies. What helps? So if someone's coming into your system and you ask them, what helps you? And they say music. And you say, oh, but you have to be on level 4 before you can have headphones. Right? What helps you? Physical exercise. Oh, you have to be on level 2 before you can leave the unit. Think of our practices again. Isn't it ask backwards? We ask people what helps them, but we don't give it to them. Okay, so when we're talking about different types of strategies, to really understand what those strategies are and make sure it gets communicated. For example, you're running a residential program for youth. You're doing this work. You know for this youth that music helps this youth calm down. That crisis safety plan should go to the classroom, so the teacher doesn't have to reinvent the wheel to understand music is what helps this student. That needs to go to the principal, so the principal understands my policy that there's no use of MP3 players in the classroom is getting in the way of these kids using self-regulatory tools. That's why there's a big leadership component in this, because this needs to translate, and the resources and policies and rules that get in the way of making this happen have to be taken on. Lots of different strategies there, reading a book, going for a walk, all of that. So this is where you really need to be creative. So for example, someone is having a hard time with on the unit, and they say exercise helps them, but elopement risk and all of that. We use those big, stretchy exercise bands. They still get what they're looking for in terms of exercise. How many of you use occupational therapists? Any occupational therapist in the room? Dance therapy. Okay. Occupational therapists are trained in sensory issues. And if you have an opportunity, find them, use them. Because one of the things they teach us is that a lot of behaviors and symptoms are seeking sensory input. How many of you work with individuals who cut? Okay. I'm sure you've asked them why they cut, right? So, if you ask someone why they cut and they say, because I'm numb, I want to feel pain. If that person has open cuts, we'll give that person Tabasco to put on the open cut. Same stinging sensation, they don't have to cut. If someone is triggered and need to do something to manage what's going on, it's harm reduction until you get to where you want to get them. Or someone may say, I cut because I want to see blood. A little tube of red food dye popped in the microwave, they can paint blood on their skin. You achieve what the person is trying to achieve to help soothe them, and it's harm reduction. Brian talked about dissociation. You guys familiar with dissociation, right? So teachers, Bruce Perry's research tells us actually that dissociation is the most common coping skill for children under 10. How many of you have kids under 10 that are just in la-la land? They leave. What's the problem in our systems? Because as adults, we will engage that child who's dissociated in the verbal world and they're not there, it gets diagnosed as oppositional defiant because they're not responding. So once you understand the science behind this, you begin to understand this. So adults dissociate. How many of you are familiar with fireballs or lemon tarts? Those very hot or tart things you pop in your mouth, okay? Someone who dissociates would carry a fireball in their pocket so that when their forehead starts to sweat, they know they're getting triggered, they know they might dissociate, they pop that fireball back in their mouth, they're back. Strategies. When we're talking about how do we take trauma-informed care out, is what strategies and tools have we given people when they're walking down the street and they see their dealer and they get triggered? What tools do they have? Having a fireball in your pocket is a tool. Other examples of this. Drug court. Do you have a problem-solving court or drug court in town? You have DWI, okay. So we're working with a drug court in both Queens and Brooklyn, okay? So in Brooklyn, the judge understood what we were talking about, this is Judge Ferdinand, about giving people tools. So if she has someone who is in her drug court that maybe have relapsed, what she'll do is she'll give them a disposable camera and tell them, I want you to go out there and take pictures of what matters to you the most and what you will lose if you relapse. The camera comes back to court. 2 albums, pocket albums are created. One goes to the client and one goes to the judge. That client walking down the street gets triggered, has a photo album he can pull out to remind him of what he's going to lose. There's a tool that that person has. When that person goes back to court, the judge reviews the album with them and asks, how's your daughter? Whatever the pictures are that matter to them. Those are tools. Other wonderful practices and tools we've seen there. Also in the Brooklyn Drug Court, when the judge remands a mother to jail that gets separated from a young child, they have donations of children's books. The mother is videotaped reading a children's book. The book and the video goes to the child. The judge's philosophy is, if I disrupt the bonding, that child will be the next generation that will be in my court. Prevention, understanding the impact of trauma, and a lot of what we do have implications on this. The latest one that they have, which is actually very exciting, they're just piloting it and they're seeing significant results. 3 times a day, they created a software program, courtesy of, I think, NDRI here in New York. A software program, 3 times a day, a text goes out to all of the individuals involved with drug court, about 500 clients. The text comes from the judge. And they're inspirational texts. It could be 1 step at a time. It could be, don't forget you're not alone. Their review of this is a lot of the individuals. It's automatic. It's an automatic text. But a lot of people feel like it's the judge really sending them a text, and that they're hanging on to that someone is there for them. Those are awesome strategies. If you think about it, we understand trauma, we understand. So some other issues around trauma. We talked about loss of control. I was just in Boston where they process 600 individuals in the homeless shelter every day. The social workers were complaining. Like, we do our best to find people housing. We bust our butts trying to get the best housing for folks. Some stay for 2 days, some don't even show up. Is this a problem here? I said, okay, we see this. So when we dug deeper, what did we find? Because a lot of housing programs take over control. Sign over your Social Security check. Sign over your life to be in this housing program. If that's a big trigger for folks, people would rather live on the streets and have control than be in our programs that take over control of their lives. That's trauma playing out. So think of your programs, think of the power differentials in your programs, and where are those all played out? And how do you then take your programs and say, we need to understand that this is a significant trigger for folks. The two most common triggers we've found in our work are loss of control and lack of predictability. If I don't know what's going to happen, the stress hormones start pumping. I probably am revving at 70 miles per hour. So simple things, corrections. We were working with correctional systems where they still process women, especially, the same way. But when the women come in, they say, this is what's going to happen. We will take your clothes away. You're going to have to shower. We're going to do a cavity search. Then you're going to go here. You're going to go there. Significant reduction in violence during the admission process because the women can predict what's going to happen to them. Predictability. How can you build in other predictability in your programs, whether it's probation? Is it predictable? Do people know when the people they care about go on vacation? Do we announce our vacation to the people we serve? Do we announce when people are leaving? Predictability. Because if people are revving at 60 miles per hour, you look at every part of your practice and wonder, is this going to make people rev faster? Make sense? Oh, this is a strategy they use in Massachusetts. Whenever someone's having a hard time, they ask the person, are you hungry, angry, lonely, tired, or thirsty? They hit on one of those, they comfort, aggression, and violence goes down. Again, leadership is necessary for this. It's a great program, but if you don't even have crackers or bottled water, don't ask the question. You have to have the supplies. Always helpful to ask what does not help you when you're upset. So, what do consumers say? In Massachusetts, they asked consumers what they find helpful. Out of 185 adolescents, 83 said, talk to me. 75 said, leave me alone. You never know. The people we serve are the experts at their lives. We have to ask. Just because it helps us doesn't mean it will help that other person. Okay, so we talked a little bit about organizational trauma. You can't see the top. This is basically, you can find this in the internet. This is Bruce Perry's work. And basically what Bruce Perry is talking about, and this is where the neglect issues are. So for example, the diencephalon is the part of the brain that develops as a result of interaction with the environment. That's you're rocking and all of that. So you see, that is where they need to accomplish affect regulation, motor regulation, and all of that. And basically his theory is, if this person is so dysregulated because of neglect or any other reason where there's not enough development in that part, you can do all the CBT you want. You have to attend to this part because they cannot pay attention. So that's why a lot of strategies of this are all about soothing that. Music. So one of the strategies Perry does, for example, he works a lot with children with autism. He assigns parents hand massages. Hand massages are patterned, rhythmic, repetitive, 3 times a day, and they're finding a significant increase in attention span because that part of the brain still can be developed. So this is basically, and you can find this, basically understanding what part of the brain may have been affected. So I'll talk a little bit about organizational trauma. That this is really, we all have stressors in our organizations. Does this look familiar? Right. What happens with all of those stressors? We begin to lose meaning and purpose in our work. We decrease creativity. We see absenteeism, inability to innovate. Organizational impact, we see workers' comp. My favorite, creation of additional positions to supplement lagging productivity. I'm sure some of you have seen that happen. Okay, so there's both individual and organizational impact of organizational stress. Here's one of my favorite data. The Gallup poll in 2009 took a look at many organizations and found that in the majority of organizations, only 33% of the employees are engaged in their jobs, 49% are not engaged, 18% are actively working against the organization. Is this surprising? No. I mean, how many of you have coworkers that basically say to you, I punch in and out, leave me alone? I do my work, right? But take this from a trauma perspective. If staff gets traumatized at work, what is the most common response to trauma is disengagement, which is, you're not going to hurt me again. So it's no surprise. I started this work because I would get called into organizations. I'll come in, and inevitably, someone will talk about a sentinel event, a successful suicide, a death and restraint. We'll talk about something happened here. Then I'll ask how long ago, and they'll say 4 years ago, 5 years ago. So it became clear that a lot of traumas in organizations that do not get addressed fester. And people speak about it as if it still just happened. So that's why I ended up really focusing more on organizational trauma, healing the staff. So really your task, especially with dwindling resources, is to re-engage those 49% and begin to understand what is it that they need. How many of your therapists do individual therapy? Okay. 50-hour sessions? Probably average 7 sessions a day. When you hear the horrors of the world day in and day out, session after session, do you have downtime to decompress? Because if you don't, it alters your view of the world. Do you have space in your programs where people can run to and say, I need 5 minutes to recoup? When we're talking about organizational trauma, secondary trauma, it's all about self-care. And it's about organizations providing the space for that self-care. A lot of organizations we work with do yoga, meditation. They put things in place in the system, understanding that mental health practitioners are the worst at self-care. I was in Michigan in a community mental health program that's running a hotline. And their policy is when the incoming person is getting report from the outgoing individual, the incoming person cannot let that outgoing individual leave until they're convinced that that person is safe to drive. Because they sit there for 8 hours listening to the hotline. And they say it can take anywhere from 15 minutes to 4 hours to do that process. But they won't let that colleague leave until they feel that's safe. Think of what we do in our systems. Individual therapists, 7 hours, 50-minute sessions. At the end of the day, you punch out as if nothing happened. Where do you decompress? Where do you unload? Is there clinical supervision, or do you go home and kick the dog? It comes out somewhere. So when we're talking about chronic stress, organizational trauma, the goal of organizations is really to help individuals in the organization to be well and to build resiliency within their system. The last example I'll give you, and we'll go on break. Program in Salvation Army in California. All the staff carry around Tic Tacs. You guys know what Tic Tacs are? Breath mints? They all carry around Tic Tacs. Tic Tac stands for Trauma-Informed Care, Trauma-Aware Care. If a staff member sees another staff member who's having an interaction that's not that particularly trauma-informed, the staff member can come up and say, I think you need a Tic Tac. If they see an interaction that is particularly trauma-informed or compassionate, they can say, you deserve a Tic Tac. If someone's having a hard time, especially with their cases, they can go to their supervisor. Instead of asking for clinical supervision, they'll say, I need a Tic Tac. They have demystified trauma-informed care by doing that, and they built it into their practice. So what we're talking about here today, in all of today, is really understanding this is no significant change in a lot of places. In a lot of places, it's simply shifting the lens, and it's really just the right thing to do. It's all why we came to this field for. To remember that we're here to help people heal, to care for people, develop relationships, and make sure those relationships help people heal. Thank you.